Hello everyone, my name is Dr. Saurabh Gupta. I am Assistant Professor in the Department of Cardiac Anesthesia, and today we will discuss about hemodynamic monitoring. Hemodynamic monitoring is a very important concept for all those people who are working in a critical care setup. So there are few fundamental basics, the terminology we will discuss today and next in the later class. So the purpose of my presentation is to inform about the fundamentals of hemodynamic monitoring and the devices that are used to evaluate all these vital functions. So what is hemodynamics? Basically, hemodynamics is the term which describes the intravascular pressure, the oxygenation, the movement of blood flow across the circulatory system and the contraction of the heart. It is a very essential part of the critical care team. And the primary goals of hemodynamic monitoring is to maintain the adequate tissue perfusion, which is maintained by the cardiac output that is generated by the heart, to meet the tissue oxygen demands, and also to alert the healthcare team in any case of impending cardiovascular crisis before any organ injury can occur. So that to evaluate the immediate response to the treatment modalities also, like if we are giving any vasopressor or inotropes, so we have to look upon what are the changes in the hemodynamics, so that is the particular therapy is working or not. The indications are all the shock states like cardiogenic shock, hypovolemic shock, neurogenic, anaphylactic, septic shock. Whenever we feel there is loss of cardiac function due to any systemic disease or to the diseases of the cardiac itself, or in any case when we feel that there is decrease in the cardiac output. There are various terminology which are used when we discuss about hemodynamic monitoring. These are heart rate, stroke volume, cardiac output, blood pressure, the systemic vascular resistance, the the pulmonary vascular resistance, the central venous pressure, pulmonary capillary wedge pressure. So these all are known as the building blocks of the hemodynamics. Now these all things are important because there are various equations and they all are interconnected. Like if we talk about stroke volume is determined by the preload. The more the preload, the more the stroke volume. The afterload, the contractility. And one important concept of the hemodynamics is also mixed venous oxygen saturation, to look upon what is the condition of the tissue, where they are getting enough oxygen or whether they are utilizing the oxygen in proper way or not. So what is cardiac output? Cardiac output is the amount of the blood that is pumped away by the heart, by the contraction of the heart in 1 minute. So normal range is 4 to 8 liters per minute, and if we calculate by a formula, in 1 beat the heart ejects the amount of blood is known as the stroke volume, and if we multiply the stroke volume to heart rate, that we find is the cardiac output, which is around 4 to 8 liters per minute. And there is a direct relationship between the cardiac output, heart rate, stroke volume. If any change in heart rate or stroke volume is there, the cardiac output would also change. Now the cardiac output will be different for a young adult, for an adult or for a kid. The cardiac output will be different. So it is better to talk in terms of body surface area. So cardiac output upon body surface area is known as the cardiac index. The cardiac index is a hemodynamic measure that relates the cardiac output to the body surface area, and the normal range is 2.6 to 4.2 liter per minute. If it falls below 1.8, the patient is in cardiogenic shock. Heart rate. Heart rate is the amount how many times a heart beats in 1 minute. So range is around 60 to 100. If it is less than 60, it is called as bradycardia. If it is more than 100, it is known as tachycardia. When there is and the rhythm does not originate from the sinus node, or the rate is too slow or it is too fast, it can also alter the hemodynamics. For example, if the patient is in atrial fibrillation, there is a loss of atrial kick and there is also heart rate variability that needs to be taken into consideration when we are talking about hemodynamic parameters. Stroke volume, we have already discussed. Stroke volume is the amount of the blood that is pumped out from the ventricle with each contraction. The normal range is 60 to 100 ml per beat, and it can be altered when the heart rate is very fast or it is very low, or when there is any arrhythmia, so that it will cause improper filling of the left ventricle, and hence further the stroke volume will also alter. Preload is the amount of the blood that comes through venous return to the right side of the heart. It stretches the cardiac muscle fiber in the atria and the ventricles, and preload can also be considered as a filling pressure of the ventricles when we are talking in the end of the diastole, because the atria and the ventriculars are connected in between. Preload is measured at CVP when we are talking about the right side, and for the left side we talk about pulmonary artery wedge pressure. This is known as the preload of the left side. If we talk about CVP, the normal range is 2 to 8 millimeter of mercury, and for pulmonary artery wedge pressure it is 4 to 12 millimeter of mercury. Now there are various factors that increases or decreases the preload. If there is increase in the circulating volume, it increases the preload. Like in diseases like mitral valve insufficiency, when there is MR, the blood is going to the left side of left atrium, so the preload will increase. If you use more of vasoconstrictor, or there is heart failure, there is not be enough pumping of the blood through the LV to the systemic circulation, so there will be increase in the preload. In similar cases, the decrease in preload will be when there is decrease in the circulating volume, mitral stenosis, vasodilators, or there is asynchrony between the atrial and the ventricular contractions. Contractility is the strength of the cardiac muscle to push the blood from the ventricles against the systemic vascular resistance, and any condition which is affecting the strength of the cardiac muscle like hypertrophy will also affect the stroke volume. Factors that influence the contractility are many factors, like antropes will increase the contractility, hypercalcemia, calcium may stimulate the cardiac muscle to contract, it will increase the contractility, heart rate as such, increase in the heart rate also increases the contractility, and various other factors also. Afterload is the resistance against which the left ventricle has to contract and deliver the stroke volume in the systemic circulation. Normal range of SVR is around 800 to 1200, and if we talk about the right side of the heart, the RV contract against the pulmonary vascular stents. For this PVR, the normal range is 100 to 250 dyne per centimeter inwards. There are so many factors that also affect the afterload. Now the important concept is mixed venous oxygen saturation. It is the measurement of the oxygen delivery and the oxygen consumption. So oxygen demand is the amount of oxygen the cells and tissue require for their own metabolism. The mixed venous oxygen saturation, the normal range is 60 to 80. If it going below 60, that means either the delivery of the oxygen is less, or tissue are utilizing more of oxygen, so that the mixed venous oxygen saturation is dropping. There are many factors that increases or decreases the SvO2. If the demand of the body going down, then like anesthesia and various other factors, and mixed venous oxygen saturation decreases when the demand of the body increases. So there are so many other things as well which we'll discuss in the next class, that what are the various things, what are the various methodology where we can use to measure the blood pressure, CVP, and all these parameters we have talked about. Thank you very much.